Okay, I am ready to start here then. Again, greetings. My name is Drew Ferguson, Public Media Relations Coordinator for the Grey Bruce Health Unit. Thank you for joining us today for this information session. I'll be your moderator for this afternoon in both video, and there are some people joining by teleconference. Joining us from Public Health are the Medical Officer of Health, Dr. Ian Era, and also two managers, Andrew Barton, the Manager of Health Protection, and Ian Reich, Manager of Health Promotion. They may be able to provide some additional and supplementary information. The larger group includes a number of leaders from various faith communities across Grey Bruce, as I said, joining by both video and phone. So following my introduction, the format of the meeting will begin with a hearing from Dr. Arrow for some opening remarks. After that, we'll open it to the participants and their questions. And please use the chat function or raise your hand to put forward your questions. Also, I've had a number of questions that have been submitted earlier, and we'll go through those as well, because many of them are repeating probably the same themes you already have. If time does not permit all questions to be answered, please forward them to the email address provided with the invite, and we'll respond to all inquiries. Our plan is to create a Q&A document as well as other resources. So again, that email is publichealth@publichealthgraybruce.on.ca. It's also on our website as a contact us. This session is being recorded, and I better do that right now. I just realized.
Thank you for participation, maybe 15, 20 minutes, then we'll open it for questions. I just want to start by thanking everybody for the exceptional results we have in Grey Bruce. Many people around the province, around the world are dealing with way more severe situation than ours. We have 0 deaths in Grey Bruce. We have 0 deaths and 1 hospitalization at some point. There were 2 long-term care facilities in an outbreak, both of them declared over with no hospitalization or death. And truly the effort for this to happen is the public, and you are leaders of the public, you're influencers, and these results speak to the fact that over 80–90% of the public did the right thing. It is a combination of efforts of public health, the public. Our healthcare system is top-notch ready, and it has been our insurance policy that we didn't have to use. So again, congratulations to everybody around the table. You have invested effort that has been fruitful. Going forward, I'll just share my screen and I'll ask Drew to see if you can see the presentation I would have here. I see Drew nodding. So it is a presentation based on the recovery phase we're in, and going forward, what reopening means in general. And that might really answer the principles to allow people to understand how the decisions are made. And that will answer by definition many of the questions that people have. And you would hear many of these questions. By definition, you're resembling the sector that you're leading. So any question from the sector would be best answered by all of us, including yourself, if you have the information. Just to present our disclosure, we're required to present any potential conflict of interest, and I have none, whether it's grant or government funds, or other than working as medical officer of health and being in academia as faculty from the University of Western Ontario and Northern Ontario School of Medicine. The private sector, as you can see, does not know I exist, and I prefer to keep it that way. So the information in the presentation comes from Johns Hopkins. It is one of the most reputable medical schools in the States, and they have even a more reputable public health school. And they have produced a plan for reopening based on the principles that are taught in the specialty of public health preventative medicine. I should point out that I'm quite aware of the death rate rising from PowerPoint boredom, and I intend not to burden you with any details related to epidemiology or the controversial best evidence. Rather, it will be a discussion straightforward discussion and chat as we go forward. And it will be 15 minutes presentation, then we'll open it for questions. And this is the ultimate goal that all of us want, a successful reopening to go back to a normal life that we had, and hopefully a more optimal, healthy life for a person to be healthy from childhood to old age. And there is no reason why we would not be in that situation at some point. And that's the ultimate goal of public health in general, to keep healthy people healthy. Important notes, the information here, again, it's prepared by the health unit over the past 5 weeks. And it really does not mirror 100% what's coming from the ministry down the road. So far, it has been consistent because I believe we're using the same principle that are used by the ministry for the reopening plans. The goal of these documents or this set of information is to provide the group with understanding of what reopening is, how decisions are made, and hopefully we will be proactive in preparing ourselves to hit the ground running when we receive the green light, which we have received recently. And this has been an effort of the team in Grey Bruce. Our website, I should mention, has detailed information. There is a section for businesses and better recommendation for reopening. And those will be very useful if you would like to spend some time on that website. Primary goal going off in the reopening phase, in the recovery phase of any pandemic. Most of us know that we need to keep disease and mortality from COVID as low as we can, but it's not intuitive to many people that there is a second goal for public health. It is reducing mortality and disease from measures designed to respond to COVID. And I can list a list of examples. Achieving herd immunity will take care of the first one, and I'll speak briefly about this. So measures against COVID going forward could cost us more than COVID if we don't really balance walk that line, whether it's related to mental health, related to social distancing. Domestic violence usually goes up during pandemics. Heat waves will be a challenge. Usually the less affluent of us who cannot afford air-conditioned environment usually go to grocery stores, cooling centers that are available during the summer. With COVID, it becomes a challenge. So the sooner we open in a safe, responsible way, the better we'll be able to mitigate the risk in both parts of the equation from COVID and the measures against COVID. Economic impact is another factor. Income is the main determinant of health. And throughout the whole process, faith is cornerstone to humanity, to actually function, to be to take care of each one of us and all of us. Faith has been a cornerstone in the history of humanity, and becomes even more important during pandemics and crises. And that's why, the more we collaborate our efforts and coordinate it, the better of results we'll get. So lessons from other countries. Some other countries opened in different ways. There is a stepwise relaxation. That's the first one, and that's the better practice, and that's what our government, to my delight, has followed. There is, this slide talks about the experience in Asia. They have been very effective in controlling the disease. There is experience from Europe. I'm not going to dwell much. I'll be more than happy to provide answers in the question period after, or later by email if you wish. Europe had different experience. Sweden did not implement the restrictions we have, and they basically gambled on herd immunity, saying if we reach 60-70% to protect the population. The result wasn't very bright. The data came out a week ago or a bit more, 10 days ago, and reflected that their herd immunity was not reached. They reached 7%, far from the 70%, and their death rate count was over 4,000 versus the 3 Scandinavian countries that compare very well to them, Norway, Denmark, and Finland. Combined, the death rate number was 700. Again, our approach, I believe, has been very appropriate comparing to other places. In the US, there are different approaches, regional approaches, and the numbers we see there are less than optimal. Herd immunity could be achieved in different ways, could be phased lifting restrictions and vaccine. There are different candidate vaccines are still in trial. The best estimate I would get is from CDC Atlanta, Center of Disease Control, one of the most robust public health organizations in the world, the equivalent to Public Health Agency of Canada. And they estimate by the end of the year there will be a vaccine. Within a few months will be the mass production for the public. There are different approaches. One of this dynamic physical distancing, which is to say, let's open for 2 months, close for 2 months. Nifty idea, but practically wouldn't probably work, especially for businesses. Uncontrolled outbreak, let it burn through. Again, that's probably Sweden's approach, more or less. The first approach is what we have advocated for in Ontario, and the government, to my delight, followed. Hammer and dance is to close everything for 6-7 months and open it, and it will be gone. There is no evidence it would happen in China. They did a very robust job, but still trying to screen people who would come to China at this point to weed out potential infection. Herd immunity, how much immunity is necessary? If we have immunity through vaccine, it will be similar to measles. One day measles was causing fear and death in Canadian population. Canadian children died of measles, and now it is unheard of. Some physicians go through their career and might see a case, might not. So herd immunity is essential. Vaccine probably is our silver bullet going through this emergency and to a stable situation that we would have. How long the immunity of COVID lasts, the last question. I mentioned before jokingly that I don't know and nobody knows. And if somebody knows, they should go to Stockholm, pick up their Nobel Prize. We have some indication from the coronavirus family that there is immunity that lasts months to years. It is really difficult to predict ahead of time how this virus would behave, especially it's novel, jumping from the animal host to the human host. There is a mutation by definition, and that mutation can have inherent risk of lower immunity when it happens, or less than periods of immunity comparing to other viruses of the same family. How much herd immunity do we have right now? It's probably less than 5%, definitely. Sweden had no restriction, reached 7%. We're way in better shape, and we're the victim of our own success. The more successful we are in controlling the outbreak, the less herd immunity we would have. How fast herd immunity will build, that would be depending on the method we use, whether we let it burn through or control it. And the better approach is to have controlled way to doing it. Understanding the reopening, we have indicators we usually look at to ensure how fast we go in the reopening, and some of them are related to the virus spread. That's epidemiology from us. Some of it related to system capacity, how many beds in the hospital, and other factors, how many healthcare providers available, and the testing capacity, how many swabs we have, how many people able to do the testing, how much capacity in the laboratory to perform. I can attest firsthand we have a second to none system with testing and public health protocols to be able to identify cases as we go. And if I may, going forward, we're going to see sporadic cases, and we're going to see clusters. We're not going to see outbreaks if we do it right, and I've seen no reason why not to. Because if we're able to identify these cases as soon as they happen and have contact tracing and contact management, we will be in a place where outbreaks would not exist. And that's the goal going forward, and we have capacity for it. There are 3 phases, and the number 3, Could it be 4 or 5 phases? It could be, but 3 is a reasonable number to work with most of the education about pandemic and relaxation. 3 would be a reasonable number, and you can see it's a spectrum of activities that we have and subsectors in the community. One on the extreme safe and ready to open would be golf courses, for example. And it depends on different variables. I can list the variables first. The amount of space available, the number of people in the activity, the amount of contact between people in the activity, and the time that are staying in contact. So you look at golf courses, huge amount of space, low number of people, they're not contacting each other much. So that's safe to open. On the other side of the spectrum, bars or movie theaters, large number of people in a small space, and there is common surfaces to be touched, and the time frame is long, the contact. So you would see different activities on this spectrum, and usually faith-related activities would be in phase 2, rightly so. So I wasn't surprised to see it in phase 2. I would have been surprised to see it in phase 1 or 3. And those are the variables I mentioned: the time of contact, the number of people in the activity, and how modifiable the activity could be. And this is just an example of where these categories or businesses or activities would fall. And this example is from the Johns Hopkins reopening guiding plan. These documents, by the way, could be found on our website, and I would advise the group to spend some time checking that website to understand this part. And on a daily basis, there is new information that could be useful to you and to the community you lead. Implementation, again, in 3 phases, and the length of each phase should be 2 weeks or more. It can be under 2 weeks, and that's related to the characteristic of the virus. The incubation period is about 7 days. Most people would have 7 days, could be up to 14, but 7 is the majority. Then a person would develop symptoms, then they will be tested after a day or 2, then the result will come back after a week. So any case that happens, any infection that takes place today will not be detected until 2 weeks from now, when the disease surface and the testing happens. And for that, we need to wait 2 weeks after this reopening. For example, Friday we start, we wait 2 weeks, and if there's a spike in the cases, we would act accordingly. And there are one of 3 decisions: either to proceed to the next stage, or to lengthen the current phase if we're not sure, or retreat to the previous stage. Hopefully we're not going to be in the retreat. And usually 3 to 4 weeks, again, more than 2 weeks. Sometimes it's not really clear. We have, for example, right now, the anti-racism protests. That's going to be a confounding factor in figuring out if the increase is from the reopening or from the demonstration. However, we will manage through to find out the balance to figure out if the phase is complete to be moving to the next phase or not. Public health agencies have multiple things to support you and support the community and the reopening. And it is on this slide for your review. The last part of it, communication. Communication is really key. Over the past 3 months, the team here has worked on hundreds of items, and they've been burning the candle at both ends. And whether it's related to testing or contact tracing, there is a communication component to any item, and sometimes the item itself that we work on is communication. And to reassure the group, capacity for case management and contact management. These are 2 processes that we do really well. We do in the background. They have to be done to ensure the confidentiality of people. So we have 99 cases, but that means we have called these people on daily basis for 14 days at least until they recover, sometimes longer. We have to contact them to get information where they were, who they contacted, then call all these people and evaluate the risk of that transaction or that interaction. And if the person who was contacted has high risk or identified has high risk exposure, we will contact them. And again, we might be contacting their contact as well if they become a case. So the 99 cases add up to over 2,000 calls to different people, sometimes repeatedly. And there is a metric from the target from the ministry to call cases within 48 hours, to call, 90% of the cases within 48, I said it wrong, call 90% of the cases within 24 hours. That's a target. Our performance has been 100% of the cases have been contacted within 24 hours. And if it is a long-term care, high-risk situation, we're on it within minutes, not hours. There is evidence of hierarchy. PPEs, you can see it in the bottom of the pyramid, upside pyramid. It's the least effective. We recommend it to everybody, but it's not silver bullet. We shouldn't, assume if we are putting a mask or somebody's wearing a mask, protection has been ensured. You can see in administrative controls, engineering controls, physical distancing are way more effective. And the combination of these things is what would ensure that activity in your church or in the community is safe. And again, the plans that we've been working on and the regulation that will come from and the guidelines from the ministry would reflect ways to ensure this is guaranteed. Next steps in reopening, again, it's work for all of us around the table. Public health work would be summarized in this list. And that brings me to the end of the presentation. I would encourage everybody to go to our website, spend some time there initially, then it will be 5 minutes a day just to see what's coming on daily basis there. These are the references, and I'm open to questions. I'm gonna stop sharing my screen so we go to the full group.
Thank you, Dr. Era. I received about 35 or 40 questions from emails from everybody, and I'm going to put out a few of them forward to Dr. Era. And what we don't get to, we will provide a question and answer document that'll be circulated and posted on our website. But I'm going to start with what was probably the most common question amongst participants asking their question, and that's to do with singing. And what is the recommendation for singing, knowing that singing in a closed space spreads droplets farther than ordinary conversation? So will congregational singing during worship be forbidden even if physically distanced? And what would be the safe distance considered for singing? And as one congregant thought, was droplet borne rather than aerosol, therefore singing should be fine. So there is some question about that. And the last question related to singing, if attendees are wearing masks, may they sing?
So it is, again, a spectrum. There is risk with any activity. Singing is a high risk activity. It is as high of a risk as coughing. If somebody was carrying the virus and coughing, it will be very risky. We have strong recommendation against, I haven't seen the guideline from the ministry or the regulation, whether this would be mandated or not, but in general, it's strong recommendation against. Wearing a mask will reduce the risk. However, it's only reduction. There was a church in Alberta, I believe they had an outbreak, and they developed a useful plan. And my understanding, it did not include singing. So that's in summary. That activity is high risk. There was a recommendation not to have it. There was a part of the question about the safe distance. Again, the distance of 2 meters, is it past 2 meters there is no risk? No, it's not. It's just a spectrum. The closer a person gets, the more risk there is. The recommendation from World Health Organization is actually 1 meter, because the recommendation is designed for the whole world, different environments. In North America, we tend to have more space to everything we do or have. And that's where the 2 meters is. However, with singing is similar to coughing. 2 meters would not be sufficient.
Thank you, Dr. Era. You alluded to masks. That's the next question I received considerable concern around whether masks should be obligatory or recommended, as well as the social distancing, etc.
So the evidence about mask has not changed. We have it before this pandemic, and there is different scenarios to use a mask. If we're talking about healthcare system, a person's trained how to use it and when to use it, that's a different situation. There is evidence there for it. N95 has a specific scenarios with aerosols producing procedures. For the general public in public spaces, in churches in this case, any type of mask would do the trick, would have the same efficacy. More specifically, whether it's 95 surgical or handmade, homemade, it would have the same efficacy. And the efficacy is to protect people around the person to a certain degree from the spread. There is some protection to the person themselves that is countered with the fact that the person who's wearing a mask keeps touching their face more frequently. So the benefit for the person wearing the mask is not there. There are some countered with some other some protection countered with the risk of or the harm of touching one's face. However, the remaining balance would be protection for people around the person. Is it recommended? Yes, it is recommended based on the community spread and the opening stage that we're in. So if you will go back to February, March, and February there was no community spread. So wearing a mask would be futile. So there was no recommendation to it. In April, there was community spread. However, we had complete social distancing. So there was no point of me wearing my mask sitting in my own living room and nobody around me. It becomes more useful, specifically useful in the reopening stages. And that's why the recommendation changed in May. Now it is time to use it in the public. And with again, it's not replacement to social distancing, it's augmented to other measures. It's just one of many other activities that we can do or measures to protect all of us.
Thank you, Dr. Ara. Moving on to a number of questions with regard to weddings and funerals in light of the 30% capacity in the facility or a group of 10. What applies in terms, which one applies in terms of a funeral or a wedding in a church? Is it the 30% capacity or the group of 10?
So this question was immediately raised when the announcement and we saw the guidelines. I presume there's going to be more clarification from the ministry. It's worth mentioning that all these restrictions come from the provincial order. So it's provincial order that is going to be lifted by the province. The medical officer of health position has no authority to override them. We have the authority to restrict further if the need be. In this case, there isn't. We have very positive results. So going back to the question, we interpret what comes from the ministry. We help the businesses and the community to have the right interpretation of these guidelines and regulations. But before we receive them and we receive them in writing, it's difficult to navigate what this means. If part of the recommendation says 10, the other part is 30%, which could be more than 10, easily more than 10, and how they would fit. So we would have to wait to hear these guidelines. And I would refer to Andy, the manager with us online, to see if we received anything today that I'm not aware of regarding this question.
Thank you, Dr. Ara. No, I mean, at the moment, we are still relying on the Stage 2 framework that was released yesterday. Beyond that, exactly as you said, you know, it's hard to be definitive until we really see the regulations or the specific guidelines. It may be that there's intended to be a difference between the ceremony in a place of worship, where we have the 30% guideline, and then the language around weddings, funerals, and similar gatherings talks about venues. Venues can conduct those ceremonies, so it might be that means a wedding or funeral event outside of the site of the church or so on. But I have to really say that's me speculating based off the limited language we've seen, and we really do need to see the official guidance before we can definitively say.
If I may interrupt, the regulations for the funerals and weddings being restricted to 10 people, I do believe is because people will travel to those events if there are more people available, because a wedding, like I have this church that seats 600 people, 30%, I'm never even gonna hit that capacity in my church. But if people are coming from all over Ontario and possibly rest of Canada, that increases it increases the chance of the virus spreading. I believe that's what the part of the rationale behind those limitations are.
That's a really good point, and I've heard a couple other points. However, all of them would be, more or less speculation until we see the guideline and the recommendation and the regulation. One of the other reasons that, as an organization, as a church, you have full control over the environment you have, whether whatever the ceremony is or the activity is. However, if you have a wedding in a private house or in a private property, the lack of control, whether it's for disinfection or other aspect of it, controlling the numbers of people attending, like you said, might play a role into this recommendation. However, my understanding there will be some clarity about this point coming forward.
Thank you, Dr. Era. Well, further to keeping Andrew online here, I've got a question with regard to the physical facilities of the churches. Should washroom facilities and places of worship be open in conjunction with the worship? And how often should the washrooms be sanitized during a morning service? In light of this, should someone be assigned to wipe down the surface or provide sanitizing wipes after each washroom visit for each individual? So just generally in the building itself, what other disinfection protocols need to be followed to reduce risks, such as do we need to steam clean carpets after meetings, etc.?
So again, similar to the last question, difficult to give definitive answers to anything that might be caught by the guidelines or regulations until we actually see them. Talking about sort of just general good practice though, what we've seen in most other facilities that have reopened recently is that the reopening of washrooms has been part of that. I suspect that would be the same for a faith group, that you would, it would make sense that you would need to have access to a washroom. So that's an assumption on my part, but I think a reasonably good one. In terms of cleaning and disinfection, we're actually, in lieu of any other specific information, we are basically linking to the PHAC advice, which is a minimum of cleaning of twice in a day. Obviously, the way that churches are typically used is not sort of a consistent use day on day. So that could be presumably moderated to the times when people are actually in the building. And I mean, if you have very large congregations, or that might need to be modified slightly, but I think that kind of advice is typically pretty good. In terms of how to clean, the good news is the virus is relatively easy to destroy with normal products. So a normal disinfectant with a DIN number, following manufacturer's guidelines is an effective way of doing that. I think those are probably the main points, but certainly there may be more when we come to the actual guidance, and obviously we will make sure that is communicated through the website and through other channels as soon as we know.
Thank you, Andrew.
Sorry, Drew, if I may add there, I have received questions from different activities, businesses, organizations in the past few weeks. By definition, I received most of them. In every single instance where I directed the person to the website or to the specific link on the website, universally the response was, "This was great, answers all my questions. More people need to know about it." And again, with communication, too much is not enough, and that's why I'm repeating. I'd really advise people to go there. There are many questions that you asked, and you will be facing from your organization or the the people you lead, most of it would be answered there. And if there is any complexity about the answer or question that was not answered, our team will be more than happy to provide more clarification or answers.
Further to that, Dr. Ara, I'll note that if everybody looks to their chat room, they'll see Ian Reich has posted a link to our additional resources. That might be of value to everyone to have that link available to them, as well as our website. I'm going to move on to another question that sort of circles around a number of issues, and it's with respect to should they take attendance or take consent forms for the gatherings, and I'm thinking there's thoughts there with respect to contact tracing and that kind of thing. And then when they are in a congregation and in a meeting, what kind of monitoring of physical distance should be undertaken? Should there be a monitor for physical distance?
So these are all good questions. The more we do of this, the better in general. However, is it practical to do it if people are going to be writing their names on a sheet when they enter the church? There is a risk of infection transmission with that activity itself. Everybody's touching the same surface, and if one person was sick, touching that pen with the other person. Is there an electronic way to do it for people who attend a specific day to send an email to confirm, or direct them to actually take note that they came here that day, and later if there's an announcement there is a case on that day, it's easy. The Public Health Ontario has produced a software to be installed on cell phones and will do the tracking, all these things automatically. So a person, if they have been in contact with any person who carries the cell phone with the same software, the software will record who was in contact with that person and for how long, and automatically would send a message to all cell phones that have been contacted by, or to people who are carrying cell phone who've been in close contact enough to qualify them as a exposure. Again, if that could be an easier solution if people direct their group to consider using that cell phone app, and it's just been in development. It will be released very soon. I would hate to disappoint you that the answer to the question, which one of these can we do, and how many and to which degree, it really depends on the setting. If you have a group of 200 people, it's different from a group of 10 people. And if you have people who can document very well on their own, there is no need for the church to do that. There is the question of privacy and legality, and that's a question that I wouldn't be able to answer. I wouldn't be able to give you a recommendation to collect information of the people who would go into activity, because that's privacy, and you know that advice would come from the legal that your organization consults with, not from myself. So again, I hate to disappoint you that the answer is not black and white. The more you do of them, the better, as long as it's safe.
Thank you. I see Mike has put his hand up, so I might ask him if this is supplemental. Mike and Formosa, go ahead. Sorry, we're fighting the mute button. Okay, you're there now.
I had a very long meeting with conference meeting with our bishop today in Hamilton Diocese, and we were bombarded with a whole bunch of information I'm going to try and process through. One of the things that he mentioned was reporting cases of COVID-19. If someone in our congregation, our congregants or parishioners have attended a Catholic or have attended church service wherever, and we have a responsibility to report that to you, I suppose. And it was also said that if we had a difficulty getting hold to the local MOH representative or whatever it was, that we could go through the diocese. Now, that having been said, I believe in cutting out the middleman. Is there is there a way to report directly to you if our churches have been exposed to the COVID virus?
So there is a very robust system, public health system, surveillance, active and passive, sentinel, and enhanced. In the passive, although the word seems passive, sounds negative, it is actually the most robust. Any person who's diagnosed with COVID anywhere in Ontario, the result will come to our office by law. The physician who ordered the test would let us know. The lab that processed the sample and got the results will report to us by definition immediately. There is no need for any other organization to be the middleman or to be faster. It wouldn't be faster. And this would apply even to organizations that deal with healthcare. So and this is where I mentioned I would like to assure the group that we have ability to track. If there is a case, there is always anxiety when people know about it, and there could be a breach of that confidentiality of that person if the reporting happened or people talked about it. We do this all in the background. I can give you an example when there was the outbreak in Mapleview. It's a long-term care that by law we have to report and post. If there was a case there was potential contact of people who are contacted. So in that case, there was one case and 4 other. On the same day, and this is theoretical more or less, the numbers could be different. On the same day, all these people notified that you've been in contact with a COVID case. Except for the case themselves, they know that you are a case. So on the same day, 5 people left the organization for a period of time, but nobody knows, including the 5, who the case is, except for the case. Okay. The employer would not know which one of them is a case because there is a certain amount of stigma, and it's private information, confidential patient information. So we do this in the background, and it is done way faster than other people think. Like we had people reporting out to us that there is a case in this organization, and we already had contacted the person and provide them the advice that they need to do, contacted their family, provided them with the advice proportionate to what they need to do, and did the contact tracing back in time and forward in time, who the people who are exposed to that case to go get tested or monitor themselves, and where the case acquired the disease from, which settings, which cases. So we do all this in the background. Legally, we are the only entity in the system that are able to do it, and we have access to the list of the cases. So it's easy for us to say, well, this case acquired it from their nephew. And both the case and the nephew might not know that the other person is a case. So again, I would urge everybody to, whenever there is some anxiety about should we report, is there more transmission, we already have it. We already got it. And if people have certain questions, they're always welcome to call our helpline. But sometimes, you would report that there's a potential case in this organization. We cannot really confirm yes or no, but by definition, we already received it.
Well, thank you very much. And just while I have your attention, thank you for keeping us up to date, because you've done a fantastic job with that. I really appreciate all the work that you're doing in watching over our community and our safety. Thank you.
Thank you. Thank you, Mike. We're glad to be of service, and it's a team effort. The credit goes to the health unit and the team in it, and to the public that, have been doing the right thing and making the process more manageable. Thank you.
Moving on, Dr. Arrow, there's a number of questions that circulate around whether people should even attend if they have age or health issues. Should they even attend church and simply remain at home instead? Some congregations are, 80% of the congregation over age 65. So should the church just stay closed or assess the risk, and how do they assess the risk? You become muted. Hang on. Let me unmute you. Sorry, Dr. Arrow, you were muted there.
No worries. Guilty as charged. I pushed the mute button, didn't push it back. It really is depending on the risk, the community spread at the time of the question, and the health condition of the person themselves. And with reopening, there is by definition acceptable risk going forward. If somebody has immunocompromised situation, treatment for cancer or heart or lung disease, it is definitely a situation where the person would suffer of severe disease, complication, and potential death. The advice to this group is to take all the precaution that they can to protect themselves. Attending church might be very important to the person, and especially if they're under certain stresses that, for me to say this is not essential for you, it really depends on the person. In general, our recommendation for this group to stay in social isolation to protect themselves as much as they can. If there are solutions to virtual attendance, that will be optimal. If there is a channel for people to attend from home, to see the service, participate in it remotely, that might be a solution that comes with no risk of transmission. Again, it's a situation where each person would have to assess that risk. Everybody has autonomy as an adult to make these decisions. Our recommendation is to try to their best to avoid any gathering. And I can give an example, personal example. My parents are both older adults, and they have health conditions that would, put them in that category that's vulnerable. And for the past 3 months, mom, dad, stay at home. We'll bring you anything you need. There is a disinfection station in the garage where, we see them behind their window, and it's the best situation that they can be in. Attending church or attending any other activity, if there is potential for increased risk, their decision has been, and the recommendation has been, to try to avoid any activity.
A question here with regard to, if I may, one-on-one pastoral care or couple sessions or small groups, recommendations on that? I saw you, Brian, and I'll get to you next.
Sorry, Drew, can you please elaborate?
The question is with respect to any recommendations around one-on-one pastoral care, counseling, couple sessions, counseling, or small groups, and that kind of individual pastoral care.
As long as it's done with the social distancing and the measures of disinfection, of cleaning, washing hands, and the lower the number, the less risk. The number 5 or 10 that was put by the regulation and the ministry is just a number. The lower the number, the less the risk is. As long as done with specific care, it is definitely acceptable risk for the benefit that would come out of it.
Okay, Brian, did you have a supplementary question you wanted to put in? Brian Thompson?
Actually, I was scratching my head, but I got a question. If the congregation, after meeting, someone gets COVID, is the congregation in isolation for 2 weeks?
It depends. If we go to that case and assess the potential exposure, and it's related to a community exposure, that means that the transmission didn't happen in the aggregation. If they were infectious, if the case was infectious during that activity, we will be contacting the people who were in that activity to assess how long they've been there, how close they were to that specific case, and what kind of interaction happened between them. And if it is low risk, that those people would be just asked to self-monitor for 14 days. If they were high risk, we will ask them to be tested and be isolated for 14 days, or isolate and wait until symptoms take place for testing. So there are different scenarios based on their risk factors, the time, the type of interaction, and the setting that was the situation was in.
Thank you. Moving on, we're running out of time, so I'm going to push as many questions through as I can. Is it appropriate to have paper handouts or bulletins for the congregation?
So if there is a way to do it without touching, it could be done. If it could be done electronically, that will be the safest alternative. Like, for example, offering, if the offering goes around from one person to the other, we know that there is a high level of risk of one person having the disease touching the surface and many other people. So if there's electronic payment, that would be an alternative. If there is a box where people walking in, walking out, depositing the money, so nobody's touching that surface, just dropping it in, then you leave that box with money for 2 days until, if there is virus, it is destroyed by time. That will be a safer way to do it. Again, I hate to answer with the word depends. There are different activities in different facilities that are unique. And if you look at the plans that are posted on our website or the information document, it will provide the principle to answer many of these questions. And our team will be more than happy to specifically go in with answering questions if the document didn't answer.
Okay. I'm going to ask one more question. I see someone with their hand up, but I'm going to ask this one because it's come by several times. What about adult sessions, adult services upstairs, and children or children's ministries or Sunday schools downstairs concurrently? Any thoughts around that?
The details with the announcement did not really specify this. In general, there is higher risk with any activity where children gather, and that's why childcare has been closed for the period it has. We know that children tend to have behaviors that allow more transmission, and in general, if this situation could be avoided, that will be optimal. If not, can we modify it in a way the number of kids that will play with each other would be limited to a certain number, so they don't gather in a big group, rather in small groups. Again, there's more details to it to look into it. If we can avoid it altogether, that will be optimal.
Again, attendance management. Should there be a monitor with a yardstick or a hockey stick to keep people apart? Is that a recommendation?
Usually most people follow the recommendation without any type of penalty or punishment or heavy-handedness, and we've seen this result with the general public. I would anticipate to see it even more compliance with people who attend church. By definition, people who are there to support the community, to support themselves, to have the spiritual aspect of her life fulfilled. Usually, it's a principle I use in public health. I use on a daily basis, the least intrusive. If education is sufficient, there is no need to a warning. If warning is sufficient, there is no need for an order. There is no need for further restriction. So depending on the activity, the number of people in it, depending on the compliance and the reliability of these individuals, you can make these decisions. Drew, you mentioned that there was a hand up for a question, then we didn't
I
start.
think this gentleman here, I'll unmute him. It just says owner, so I don't know the name. Gentleman in the red shirt.
He is on mute.
Yeah, I'm trying to unmute him, and my button is very slow.
Maybe.
There we got him. Go ahead.
Okay.
Go ahead, sir.
Doctor, thank you for giving us this opportunity. I've had a number of Zoom calls with hundreds of pastors across the province, and one of the concerns that keeps coming up, and I don't know how to gently say this, is we have addressed the physical needs of people, but has it been at the expense of their mental, their emotional, and their spiritual needs? And one of the reasons is, I say, we as clergy have not been considered essential workers. We have not been allowed to care for anyone in positions where they're dying or severely ill. And a lot of ministers have really taken that badly. I know the physicality thing, but you know, nurses and doctors are at that every day too. And some of these people, maybe even more than just physically dying, they know they're dying. They have some real emotional and physical and spiritual needs that we can't address. The only one that can address them is the chaplain in the hospital. Is there any thought being given to that at all?
I acknowledge what you said, and it is something that was not, did not escape our notice. The direction to restrict certain activities, certain groups, again, comes from the province. I have the ability to influence, to advise, but not to make the decision. I acknowledge the importance of the spirituality aspect of any activity we have, in any situation we have, especially in what you described, the end of life. To the best of my understanding, the risk of transmission, when you see people who are trained to do it on daily basis, physicians, nurses, healthcare providers, these people on daily basis shake the devil's hand to try to manage a disease that's very infectious, more infectious than COVID, for example, TB or measles, and more severe than COVID, whether it's meningitis. And they do it on a daily basis with every case. So they're trained in it. For example, I can give you an example. For the past 20 years, I've never touched an elevator button with my finger. I always use a car key or something else. In subconscious, I was trained not to touch anything. So in the middle of a pandemic, the decision is to allow these individuals to perform their activity related to response to COVID versus the other groups. Again, it's a decision that was made in an emergency. By definition, doesn't have to be 100% right decision. It usually is added value. And as I mentioned in the slides, in the reopening stages of the management of the pandemic, balancing the risk from COVID versus the risk from measures against COVID, including mental health and the need for spiritual support, is factored in by myself, factored in by the people who are making the decision in the ministry. Again, to the best of my understanding, and I'm not around that table that makes the decision, that was factored in, that as soon as we have control over the outbreak in the first wave, we go to the reopening stages. That's what happens. And that's why you would find churches in the first part of the second stage included. If you look at the evidence, they could be at the end of the second stage, could be at the start of the third stage, depending on the situation you would have. Like if you're reopening without going into much details, depending on the community and the need of certain activities in the community. And obviously it was factored in for this stage immediately.
I have a quick question.
There's a number of people with questions, so we'll see if we can get to them. Go ahead, Bob.
Thank you very much. One of the groups I represent has outdoor services in the summertime. It's the Bruce Beach Cottagers Association on Sunday afternoons. Does having an outdoor service mitigate some of the risks? And I would think my particular question would focus on singing.
Outdoor activities are less risky than indoor. Definitely there is reduction in risk there. Would the reduction in risk suffice or enable singing? It really depends. If you have 6-7 meters between people and they're singing, that's different from 2 meters. 2 meters singing is like 2 meters coughing. That's a
How
really
about
good
4
metric.
meters?
Like sorry?
How about 4 meters?
Again, it's less risky than 2 meters, but is it zero risk? Probably not.
Okay,
Coughing travels. If you cough, you can appreciate it could be meters, not just 2 meters.
thank you.
Thank you. I
Drew,
have a
sorry, Drew. Are we not allowed to go further?
yes.
I can cancel whatever I have next, and we can go
Okay.
further.
I do have additional questions, and that's what I was going to just ask you if I can keep on going. I have Jason Ashby. Jason, can I unmute you and can you pose your question?
Yes, I'm just wondering if you have a sense, the Premier said that the stage 2 guidelines or some details would be out soon. Do you know, like, are they out? Did I miss them? Or are they coming next week? Do you have a sense?
So in general, the ministry has been able to provide outlines within 1 or 2 days. And yesterday we received some, today we received some. I'll turn it to Andrew to see if we received specifically the regulations for churches. I know an hour ago when I asked you, the answer was no, but you might have received something in between.
Yeah, still not aware of anything. I am, they should appreciate quite a lot of the regulatory change for businesses and things as well, actually come into action for Friday, midnight, Thursday night. So I am expecting to see the regulatory change by end of day tomorrow at the very latest. In terms of the actual additional guidance, that's less easy to predict, but the government has been very responsive, and I would expect to see it, within the next several days to a week, probably maximum. But we don't have any additional knowledge. We actually received those guidelines at the same time as other people.
Yeah, sorry. When I was looking on the Ontario Public Health website, like, I don't see any guidelines really. Even you mentioned that you've had some, but not the church ones. I don't really see much in way of stage 2 or phase 2. So would I be able to access whatever's out there through your website, or you know where I can see those?
Yeah, so our website will have them. I don't think we've seen much phase 2, stage 2 guidelines yet. The guidelines we've been receiving were some of the changes that were made towards the very end of last week. So that's probably a bit of an indicator, but as to how long it takes to get those out.
So the Grey Bruce site can still be sort of a one-stop shop for us. We can just keep watching you, and we'll be able to find our church stuff when it becomes available.
I believe that will be the, not the only way you can get that information, but maybe the easiest, yes.
Thank you.
I'll jump in there if I can very quickly. Absolutely. The recovery section of our website will be updated as soon as we have those official documents. Right now, the general framework is available on the recovery link that I did post there. But we are waiting for definitely that more wholesome document that definitely supports your specific sector. And in what I've read so far, that is to be coming very shortly. And I do have a line on a brand new health and safety document for your sector as well that's just been released from a safety sector in the province. So as soon as that is sort of posted on the website, we will definitely get that out to everyone. We're just waiting to ensure that that is official before we share it out. So hopefully you'll have some good guidance in the next couple of days.
Thank you, Ian.
And I can add, we can notify you by email for the list of emails that we have when these documents are posted.
And if people follow the situation report, which is on the front page of our website, every new resource is flagged there before it as it goes up. So watch that situation report for new resources and new information. I'm looking at anybody else raising hands or with respect to questions. I see Brian again. I'll unmute you, Brian. Go ahead. Please stand by. My clicker is a little slow. There you go.
Communion, how do we handle that? Any suggestions? I just was wondering whether we should get the members to bring their own. That way it's not being handed from hand to hand, or any suggestions on that?
That's one good suggestion to do that. Andrew, is there any specific in the section in the document we developed for churches that would deal with that part?
Again, I don't think we've seen anything specifically. Just relying on the guidance we've seen for other sectors, certainly limiting the amount of materials, food, anything passed from one person to another is pretty consistent throughout all of those. So I think that's one of those areas that if you can come up with novel or innovative ways, then that may well be the best solution.
Anybody else with any questions? I don't see. Oh, okay, Ruth, I see you. Ruth, go ahead. Oops, sorry. We may be fighting the mute button. Each of one of us may be fighting the mute button.
There. Can you hear me?
Yes, you are.
Yes.
Other groups use our church. Should we be allowing that?
Sorry, I missed what you said.
Other groups come in and use our church hall. Should we be allowing that?
Sorry, I'm Drew, would you be able to rephrase it? I didn't hear it. If you have better headphones.
I believe she's asking if other groups, outside groups from the church, can come in and use their hall, their facilities.
It's a question that actually many organizations deal with, including ourselves. If there is a way to modify the need for that, it will be optimal. If you cannot really control it, it could be not allowed. I can give specific example. Beside the health unit, usually in the summer, we have people who have no home, homeless people, and they use the washroom facility in the health unit. They use our fountain to have water. So what we decided, if we have a water source different from the fountain that's being used, so if they come in and they take a bottle, that could be an easier way than using the same fountain that the employees use. The washroom, are we able to disinfect it or clean it as frequent depending on the number of people? So if the number of people is less than 10 per day, that is doable. If it gets more, we're going to change the policy to say this is not open for public. Again, it's really specific to the situation you're dealing with, how many people might be in, and how much capacity you have to disinfect.
Thank you.
Keith, do you have a question?
Yes, I do. It's kind of similar about other groups using the church. We've had a request from a group that uses our church for concerts, and they believe that the 30% attendance applies to them. We are suggesting that it is for worship services only. What is your interpretation?
So, again, that would be a question to the ministry. If Andrew asked it, we can have the answer right away. If not, we probably would have to ask the ministry, because like you rightly said, the activity allowed 30% is for church services, and which is different from other services. Andrew, do you have specifics to it?
No, but I do believe the similar analogy that we have discussed was for regulated health professionals, where regulated health professionals were permitted to operate at an earlier stage. However, they were limited to the things that their regulated profession allowed them to do, so it wouldn't give them the ability to do other things. My interpretation would be that the 30% building capacity would be for worship, for prayer, for those sorts of things. There may be a grey area there, but I think that if you were looking at something like a concert, then the restrictions that apply to a concert would probably be the correct ones to look at. We may get more information in terms of guideline and regulations, but I think ultimately that might be a more specific question to go to the Stop the Spread website or phone number.
Thank you.
I just scanned the group. I don't see any other additional questions. Am I correct that way? If you have.
Sorry, Drew. Steve Gordon.
Oh, Steve Gordon. Yeah, I see you, Steve. Go ahead.
It was brought up, Doctor, about the outdoor services. So if we do an outdoor service, how do we manage attendance? How do we manage capacity? Because obviously outdoor, I mean, especially in rural settings, I mean, we have tons and tons of space. So what is there a limit then on attendance and how many people can be a part of that?
Again, very similar to the other answers. If the regulations addresses it, that will be clear cut. If not, I would go with the capacity inside the church, and because like you said, you can, if you consider the capacity outside that church, it's unlimited. So, and if there is a space that would allow for unlimited, without the regulation, answering that question is difficult to be. My own guess, it would be going with the capacity inside the church applied to the outside.
Thank you. Again, I'm casting through the group here and I don't see any. Oh, here we David. I will ask you to speak, David.
Thank you. Quick question with regards to baptisms. What would you recommend with that?
The same principles would apply. If any activity could be modified to reduce risk, that will be optimal. If it's not, if there's no ability to modify the risk, the activity should not happen. Is there ability to modify risk with baptism? Definitely, yes. You know, the water itself is not a risk of transmission. It is our hands, it is touching the person. And if it could be done with social distancing, with lower number of people around the service, it again is something that would be acceptable risk to tolerate.
Okay. Again, anybody else? I don't see anybody indicating any questions. There are people on phone that may want to attempt a question.
Actually, Gord Dunbar here, if I may.
Go ahead, Gord.
In answer to the question previously asked about concerts, if it's a concert, they're singing. If there are instruments, they're blowing. I would suggest that would be very high risk and therefore not allowed in this particular venue. Previously asked question about baptism. If the parents bring their own water and are the ones to apply the water and everything else is the same, that is the recommendation that we in our denomination, the United Church, have been given when the time comes.
Sounds very innovative and safe approach. Is it practical? Again, depending on the situation and the ability to have that activity done in modified way. The concert part, if again, it's like you said, if it's singing, it's high risk, but it is one person singing on the stage. It's different from everybody singing around, which happens in the singing in a church. That's the only difference in risk. However, I agree with you and I agree with Andy that we need to look at different regulation, not the regulation related to churches, rather to the concerts.
Ruth, go ahead. I'll let you unmute yourself.
There I am.
There you go.
Okay. Singing through a mask. If one person was singing at the front through a mask, would that be okay?
It's like coughing. Again, with a mask, coughing with a mask is safer, but it is coughing. In the front, yes, that means in front of them there is an open space, but the droplets dissipates in different areas. It does not float and go through the room, but again, it's less risk, but it is still risk.
Okay. Thank you.
If there is a recorded singing, could be a useful alternative, but again, I don't know how this would be perceived by the group. Like, would it be satisfactory to have it recorded before and people playing it at the time? Not sure.
Okay. Thank you, Dr. Era. And again, I'm casting a vote and I don't see any additional questions at this point. Going once, going twice. I'll maybe ask you, Dr. Era, for any concluding thoughts.
Thank you, Drew. Thank you, everybody, for your attendance, and thank you for the great work you have done over the past few months. This success that we have is direct relationship to your recommendation to your groups, to your churches, and the most important part going forward is in all stages of reopening, the same teaching, hand washing, staying home if one's sick, coughing in their sleeve, really stand. And it's for all of us as individuals to protect our families and to protect the community, and specifically the most vulnerable of us, people with comorbidities, heart and lung disease, cancer. And these things, sometimes they're taken for granted, but those are the things that flatten the curve. Exactly what our mothers have told us all along. Wash your hands, wash your hands, wash your hands. So again, I might sound like a broken record, but if it is going to be for the goodness of all of us, it will be good recommendation for all of us to actually convey it to our audience at different stages, hopefully for a successful reopening for all of us. Thank you all.
Thank you very much, Dr. Era. And we got, is that another question coming up or no? Okay. As I mentioned at the outset, this session has been recorded and it'll be available on YouTube. As soon as we can get that posted, we'll share that information. Additionally, as Dr. Era discussed, there's lots and lots of resources on our website. Please go there and seek out information. We also have a 1-800 number, 1-800-265-3030, and specific to COVID-19 is extension 3000. That'll give you access to people with information with respect to the regulatory environment and good advice in just general. So I think with that, I will push the end record button and thank everyone for their participation today.
Thank you.
Thank you.
Thank you.